There we go. Okay, and so for all the people on Zoom that just missed my introduction, hello, my name is Josh. I'm one of the R5s if you are unaware. And today we're going to talk a little bit about dexmedetomidine as an adjunct, so both neuraxially, regionally, and a little bit as an IV. The inspiration for this came from CAS last year because I had no inspiration otherwise, and there was a very interesting talk about a couple of practitioners that use dexmedetomidine in their OB practice. So I reached out to them to try and get information. I was promptly ignored, so I had to do my own research and present it to you here today. So you get what you get. Standard disclosure slide, I have none at this time. And where we're going to go today, we'll start with a brief introduction to the pharmacology of dexmedetomidine, a quick refresher of kind of what it does, what it shouldn't do, but it still does. It's on-label and it's off-label uses, again, just to kind of introduce the fact that we're unsurprisingly, neuraxial dexmedetomidine is wildly off-label. Then we'll talk a little bit about its use in these perineural type spaces, both epidural, spinal, regional, and then there's a fair amount of data in pregnancy and C-sections. And then a little bit about safety at the end for obvious reasons, and then some practical dosing tips should anyone want them. Okay, so dexmedetomidine, hopefully, I'm not going to dig much into this. It's a pre and postsynaptic alpha-2 mainly adrenergic agonist. Very similar to clonidine, but it is much more alpha-2 specific, and that is because of that, it has a lot more analgesic and sedative properties, which is why it's gotten a fair amount of study in anesthesia, and I'm sure why we're playing with putting it into people's spines. So really, the effects are sedation, analgesia that we're looking for. There's a handful of different side effects. The FDA in their product label has a handful that they've recognized and said these are attributable to dexmedetomidine. I've split them up mainly into ones that we would usually see in our practice, ones that are a little bit more ICU, and then just some points about dexmed use. So if we're bolusing, if we're doing short-term stuff, you'll tend to see sedation, hopefully, right? You'll often see bradycardia. With an IV, you will often see hypotension. You can also fairly commonly see hypertension, despite those being the opposite things. We'll talk about that in just a second here, just so that you can understand the why and how to expect it. Again, people in the room that use dexmedetomidine, this isn't a surprise, but it's not super well used here, so it's worth talking about. And then in more the ICU context where we're running an infusion, we're having them get this medication for several days, they can develop a tolerance or a tachyphylaxis. And when you take away their drugs, they can get cranky. A few other points worth mentioning. It is hepatically cleared, so if you've got someone that's a terrible liver function patient, you may want to reconsider or at least dose reduce. We'll see a little bit on that we're not using much for dose anyways. It's not really relevant in most of the anesthetic uses, but something to have in your mind. And then, as you might expect, administration of dexmedetomidine with most of the other drugs that we use to sedate people, you do get a synergistic effect between the multimodal sedatives. So there is evidence that it will, again, synergistically benefit things like all of our gases, propofol, midaz, opioids. So again, just to keep in mind for use. I said I was going to talk a little bit more about the hypertension, bradycardia aspect. Bradycardia, you'll almost see kind of universally, regardless of whether you're using a smaller dose, a bigger dose, infusion, short acting. It's just part of the mechanism of the drug. And it's not necessarily bradycardia down to 40, but a relative bradycardia, you're going to drop the heart rate with this medication. But interestingly, you can also get a bit of a biphasic blood pressure response. So when you are initially loading the drug, you've got a bit of a higher plasma concentration to get to your effect sites. You start to saturate receptors so that alpha-2 specificity breaks down a little bit. You get alpha-1 activity as well, and that tends to dominate a little bit when you're seeing that hypertension. So you get peripheral vasoconstriction, blood pressure comes up while your heart rate is coming down. And then after your initial bolus is done and you're switching more into the infusion maintenance phase of your medication, that specificity comes back. You lose most of that peripheral vasoconstriction. Your blood pressure will then drop off a little bit as your heart rate continues to come down. So again, just a bit of a why that happens. You can expect a bit of both, and that's sort of the timing if you're running this IV. Okay, so that's what it does. What's it supposed to do according to the FDA and Health Canada? So initially approved in 1999 for sedation in ICU, mechanically ventilated, intubated patients for less than 24 hours. So anyone that's been through an ICU knows that they very quickly blow through on-label to off-label. They can stay on this for weeks. But that's kind of the main original point of it. In 2008, they also said, you know what, this probably works very nicely for procedural sedation for non-intubated patients. The FDA didn't really give details what they were talking about with this, but Health Canada effectively copy and pasted everything, and they also gave a little blurb about what we're actually intending with this. And this is mainly where we would see it and go on label and say, yeah, look at us doing it, what we're supposed to do. So monitoring anesthesia care, things like an awake cranie, you get someone asleep-ish, or for awake fiber optic intubation, you can get someone comfortable while you get them numb. Off-label use. So there's a bunch. It's used probably mostly off-label compared to on-label. And really, I wanted to go through a few of these just to make it a little bit easier if you think you want to dip your toes in the off-label world for Dexmed. So first and foremost is pediatrics, anything. It's never been approved for children. As anybody going through residency here knows, it's used all the time in children. That's the first place I saw it, the main place that I saw it. I've seen it a few times in adults. People will use it a little bit, but any pediatric use is off-label. You don't need to chastise all the pediatric anesthetists. They're not doing anything wrong. The FDA has meetings about this, and basically they say we haven't seen any big major side effects. The current practice appears to be fine. We don't have enough data. We're going to keep monitoring, but they haven't approved anything. Other things that will get used for delirium management, again, it's just a nice, gentle sort of sedative. You just want to calm things down a little bit. This is fairly common, not for us, obviously. Alcohol or opioid withdrawal, again, very much the same thing as we would use a benzo, just calming things down a little bit. We use it as an anesthetic adjunct. Anytime you're using it for a patient that's intubated and asleep, it's an off-label use. I've seen this a handful of times. People use it to smooth out a wake up, add a little bit of multimodal analgesia, multimodal sedation, just to bring down everything else that they have to use. These two are the ones that mainly came up when I was at that CAS talk that I hadn't really heard about being used. But the presenters were very convincing, much more so than I will be. But both of these were indications that they seem to find worked really well. So the perioperative shivering, this is one that I have used just because it was kicking around in peds. You give 10 mics of dexmedetomidine, and basically it was one circulation of blood and the patient had stopped shivering. Works very well. And as we'll see a little bit later, there's really not much for side effects. And then as an anesthetic adjunct, throwing it into your spinals or your epidurals. Again, this is something I'd never heard of anybody thinking about. And you'll see why a little bit later, but it was interesting enough for me to try and talk about it. So neuraxial dexmedetomidine, first of all, why would we bother doing this? We've got plenty of adjuncts. What are we actually doing? So it's doing the same thing. There are central and peripheral alpha-2 receptors that it's going to be working on. When we give it neuraxially, it's focusing a little bit more on a lot of those central ones, and they tend to be the ones that are a bit more focused on pain. So as you can see here, this very smart sounding sentence, how it inhibits nociceptive C fiber transmission, reduces postsynaptic dorsal horn neuron activation. I've taken this from some very wise sounding papers. I will be taking no questions on the physiology of that. Thank you. But why else would we want to use Dexmed? So the low doses that we would require in epidural neuraxial stuff, you tend to get a pretty good effect, but you don't see a lot of the side effects associated with it, as we'll kind of go through. And really, there is precedent already for putting an alpha-2 agonist in or around the spine. We have clonidine. We've had clonidine since 1980, and people have been putting it in and around the spine since shortly thereafter. It has a long history. It's generally considered safe. This isn't something that we usually worry too much about. So why not just use clonidine? Luckily, there are some papers that ask this very exact question. So this paper is looking at dexmedetomidine and clonidine in epidural anesthesia. This was a prospective, randomized, double-blind, controlled trial, 50 patients aged 44 to 65 undergoing vaginal hysterectomy. As an aside, the makeup of this trial is very commonplace for what you'll see if you go looking for more stuff on dexmedetomidine neuraxially. There's a whole bunch of trials that are 50 or 50 about patients. They're double-blind RCTs, so they seem to be well designed, but they're all small. Okay, with that aside, they broke their patients up into two groups, ropivacaine and Dexmed, or ropivacaine and clonidine. They gave them same amount of local and equipotent doses of their alpha-2 agonist. They looked at how quickly their analgesia is coming on, sensory and motor block levels, sedation, duration of analgesia, and side effects. So in terms of how the block initially was coming on, the onset time of a sensory block up to T10, in the dexmedetomidine group compared to the clonidine group, you're about a minute and a half faster. Maximum sensory block level, you're about a spinal level higher. Time to maximum sensory block, 2.5 minutes faster. Time in minutes for a complete motor block, again, 2.25 minutes faster. So none of this is earth-shattering, practice-changing stuff. You're not going to run out and buy stock in dexmedetomidine and start using it immediately. But in comparison to clonidine, you can see there are clear both statistical and I would say clinical benefits if you are if you're trying to get someone numb for a very stat type baby being delivered, that extra minute and a half, 2 minutes can be a lot. Sedation, once the epidural was in and patients were comfy, these are, again, the standard sedation scores. 1, 2, 3 is all they got to. Nobody was asleep. And generally the trend here you can see is that the dexmedetomidine group tended towards a little bit more sleepy compared to the clonidine, which was potentially a little bit less. And then what did the block do afterwards as it was wearing off? So mean time to coming down by 2 segments, you got about 8 minutes more with dexmedetomidine. Mean time for regression of motor block, again, about 20 minutes. Mean time to sensory regression, 20 minutes. Time to first rescue top up, about a half an hour. And worth pointing out, I think, is that, there's a mouse. So with the clonidine group, you get about 15 minutes after the full sensory regression of the block to people asking for a top up. With the clonidine, with the dexmedetomidine group, it's closer to a half an hour after the block has regressed to when you're getting people asking for a top up. So there's some evidence then that this is also providing better analgesia, not just a longer block. And I think that that's reflected in the amount of ropivacaine that they actually had to use to keep these patients comfy while they had their epidurals. So why not clonidine? Dexmedetomidine gives you improved time to blockade, level of blockade, length of blockade, and possibly analgesia. Per this study, it also demonstrated increased sedation scores, which, depending on your context, can be a good thing or a bad thing. If you're doing a C-section, maybe not a great thing because you want a patient awake to meet their baby. If you're doing a hip and your patient doesn't want to hear the carpentry that goes on, this might be a good thing. You may not need to run any propofol. Okay, so a little bit more then about how it's actually used in those sort of regional neuraxial type settings. I've chosen a couple papers here, not because these are brilliant landmark papers that don't really seem to exist yet for this set of data, but just because these are pretty typical of the rest of the literature that I've looked through. Okay, so this first one, facilitatory effects of perineural dexmed on neuraxial and peripheral nerve block. They looked at a bunch of trials. They included 9, had 516 patients. So again, around that 50 patients per trial. And they put this in their discussion. They recognize that these are one of the major limitations is they're limited by trial size, and the data itself was also quite heterogeneous. But what they did find was pretty interesting. So I'm pretty sure all of these are looking rather than dexmedetomidine plus local versus like dexmedetomidine and opioid. I think it's just versus local alone. So these are pretty dramatic numbers, but it's because you're adjuvant versus not, basically. So in the trials that we're looking at putting it in your spinal, they found sensory block duration was increased by 2.5 hours. Sensory block onset was a little bit faster, no difference for motor. Motor block was prolonged by 2 hours. First analgesic request was delayed by about 5 hours. Importantly, they found no increased bradycardia, no increased hypotension, no respiratory depression. But the papers that they had didn't really talk much about sedation, so they weren't able to comment on that. It looked like there wasn't much in one of the papers that had gone into it, but Again, there wasn't enough that they could comment here. They had 4 trials that were also looking at brachial plexus blocks. So similarly, sensory block duration increased by almost 5 hours. Motor block prolonged by almost 5 hours. First analgesic request delayed by 5 hours, 45 minutes. Similar sensory and motor block onset times that didn't really speed that part. Interesting, they did have a little bit of increased bradycardia, that 7% of their patients versus none. I think the reasoning for this is with regional stuff, you're just using a little bit more, you're getting a little bit more systemic absorption, so you do see some of that drop in heart rate that you don't see as much with spinals. And again, this is just the one paper, but again, it represents most of what the other findings were, things that were more spinals. You didn't really see side effects in this vein. Things that were a little bit more regional, you did see a little bit of sedation, but you did not see any hypotension, no respiratory depression, and potentially the bradycardia. Sorry. Okay. The second one here is, again, adjuvant dexmedetomidine, regional anesthetic. They're doing penile block for pediatric hypospadias repair. Again, a double-blind RCT. They were looking at pain, sedation, complications. 50 children, 6 months to 6 years, and they were getting this dorsal penile nerve block at the end of the procedure for analgesia with or without dexmedetomidine. The people placing the block were blinded to it. The people assessing were blinded to it. And all of the patients were monitored in PACU for 4 hours afterwards, just for the purposes of the study. So they did find, first of all, a statistically significant difference at all time points in sedation score. So even this, again, fairly small amount of Dexmed that they were given, the kids were a little bit sleepier. So again, for whatever it's worth, this can be a pro or a con. For a post-op child, a little bit of Dexmed sleepy sometimes is lovely, but worth keeping in mind. More importantly, I think, is there were clear clinical and statistical benefits in terms of pain. This white graph, you can see at every time point, the dexmedetomidine group was clearly better in terms of pain than the straight bupivacaine group. Other findings that they had, there was a statistically significant difference in heart rate at time equals 0. So immediately after the block was placed and they were brought to PACU, the kids in the dexmedetomidine group had a heart rate that was about 15 beats per minute lower. But at all other time points, it was not significantly different. So it was a little bit of that bolus effect, and then it came down. At no point was there a difference in BP, and there were no differences in any other complications, nausea, vomiting, hypoxemia, or dyspnea. Okay, so moving on to talking about its use in and around C-sections, labor. There's a bit more evidence in this population. I think it's just easier to study. We do lots of them. They're otherwise young and healthy, and they're people that we like to get pain-free sooner. So again, just to reiterate that dexmedetomidine clonidine thing, because again, this is also a population where we've got a second patient. We don't want to be just throwing things into the mix. Again, double-blind RCT, 50 patients. I could record myself and hit play for every one of these. And they were giving labor epidurals very similar to the practice found in Edmonton, 10 mils of 0.125% bupivacaine with dexmedetomidine or with clonidine. Their primary outcome was change in visual analog scale pain. The Dexmed group, again, provided faster onset time, maximum analgesia. There was a decrease in heart rate in both groups. It was more pronounced with Dexmed. They were about 10 beats per minute lower than the clonidine group, but neither was low. So the Dexmed group was around 90 beats per minute throughout their study period, and the clonidine group was about 100. Probably the most important thing, and really the reason that I included this study, is this big blurb at the bottom. So we talked about having 2 patients and it being just a slightly more complex anesthetic time period. So maternal motor blockade, maternal sedation, maternal complications, duration of labor, rate of instrumented delivery and C-section, total analgesic needed, and neonatal APGAR scores. There was no difference between these groups. So again, taking that little bit of a long and fairly well-established safety history and profile for clonidine and just kind of copy and pasting that to dexmedetomidine. The evidence isn't truly there yet to say for sure we can do that, but it definitely appears to be the case. And really, we would expect it to be. It's the same mechanism, just subtly different in terms of specificities. Okay. Dexmedetomidine is an adjuvant for spinal anesthesia in patients are undergoing C-section. Again, we're seeing pretty similar stuff to what we saw with the previous findings about spinal. So they looked at the past 10 years, 12 RCTs, couple meta-analyses, 400 to 300 patients each. And their findings were that intrathecal Dexmed may enhance quality of neuraxial blockade, more rapid onset, prolonged block, superior peri-op analgesia, may reduce unwanted side effects such as nausea, shivering, and pruritus, may result in enhanced pain scores and block characteristics compared to neuraxial short-acting opioid, and importantly does not significantly alter maternal nor neonatal hemodynamics. So again, a couple of big points here worth highlighting. Again, it seems to be safe for mom and baby. We're getting a better block with Dexmed. Ooh, Lance Wu. And again, we're getting away from some of the nausea, shivering, pruritus. These are the things that we'll get when we're putting opioids in as our adjuvant, which do have again a very proven track record, but these are known side effects that we get, and they can sometimes be less than ideal in that immediately postpartum patient. I wanted to talk a little bit about shivering, because again, this is something that came up with the CAS, and it is something that I've moved a little bit into my own practice, and personally, it works great. So this paper was looking at IV treatments for peri-op shivering in patients that have undergone C-section under neuraxial. So they looked at 20 randomized trials, about 2,000 patients. The main findings that they had for ones that worked were Dexmed, Tramadol, Nalbuphine, Meperidine. They all controlled perioperative shivering well. There was no big difference. Once you kind of get to these top ones that work well, it works or it doesn't. There's not a huge impetus to pick one versus the other in terms of shivering control. That being said, Dexmedetomidine was number one. So you should for sure pick that. But I think, again, a point worth making is that while all of these work for shivering, Tramadol, Meperidine, Nalbuphine are all opioids, and they are all associated with nausea, which trading shivering for nausea isn't necessarily a good trade, especially in the immediate, you've just had a baby period. This one is the same idea, but a little bit different. So this is, again, neuraxial dexmedetomidine, given as part of their spinal for their C-section. And does this have an effect on shivering? This study looked at 18 RCTs looking at different agents. 2 of the RCTs that they had were on intrathecal dexmedetomidine. And both of those trials, with a 5 mic dose of intrathecal dexmedetomidine, they found there was a statistically and clinically significant difference in incidence and intensity of shivering during C-section. But they did have finding that if you cut it back to 2.5 mics, it didn't really do anything for shivering. So there does appear to be a bit of a basement dose for the anti-shivering effect here. Importantly, that I didn't say out loud, is they also found, both of these studies found that there were, again, no major adverse events by doing this. Okay. Just out of interest, there are some other interesting side potential benefits, one that is directly applicable to what we're talking about and the one that's sort of an aside. So this first one, a treatment that I'd never really heard of, you can nebulize dexmedetomidine as a treatment for post-oral puncture headache. So in this trial, there were 90 women. They were given placebo, neoatropine, or Dexmed nebs twice daily for 3 days. In the dexmedetomidine group, they all experienced resolution of symptoms being pain and headache. None of them required blood patch. They weren't completely resolved, but they were all well enough that they could carry on with their lives. This isn't a treatment that I'd heard of before. I thought it was interesting, so I threw it. The second one is, again, these patients that are getting epidural dexmedetomidine, they were looking at sleep quality in the 1 week period after having their baby. So again, finding that pain from time 0 to 3 days post-delivery was improved in the dexmedetomidine group in all patients. And again, so this is people that had dexmedetomidine in their epidural for both loading and infusion. The epidural was stopped when their baby delivered, and they had these effects 3 days out. They were still with better pain control. And then sleep disturbance, the percentage of patients that had significant sleep disturbance in the first 7 days was about half in the dexmedetomidine group. By day 7, they pretty well equilibrated. So again, not something that is going to make you for sure go out and get dexmedetomidine to put in an epidural, but points to there are other interesting effects that we can have, and it mainly reinforced that trend that a lot of the positive benefits that we see with dexmedetomidine neuraxial, it just seems to draw out the effects that we're having. Okay, talking about safety. So as just a point of interest, something that should be aware of, basically all of the literature for this is coming out of China, Japan, India, Middle East. And I make the point that, again, they've got potentially different ethics approval and publishing standards, but I don't think that's to say that obviously all of this data is trash, we shouldn't use it. But at the very least, they are working with different patient populations. They are working with different practices. So it may not be directly applicable to just take a number out of theirs, plug it in, and see the exact same benefits. Reasonably so. There is very limited data around neuraxial dexmedetomidine specifically. I would say importantly, I couldn't find any case reports of catastrophic things that have happened when this is being done, but there are also no longer term studies evaluating safety specifically of neuraxial stuff. There are lots of available case reports, white papers, conference discussions about safety of dexmedetomidine in general, but this tends to be more when it's used IV. The common themes around this are kind of as you'd expect. You've got a drug that can precipitate some bradycardia, some hypotension. And so the people that were predisposed to that were the ones that were having issues. So a lot of elderly pre-existing cardiac dysrhythmias, polypharmacy, people on beta blocker, calcium channel blockers. You give them a drug that slows their heart down and gives them hypotension, and their heart slows down and they go into sinus arrest. So again, as I've hopefully tried to highlight a little bit, we don't see as much of these type of effects when you're doing anything neuraxially. But if anyone's going to try it, while you're still working on that initial experience base, this might be a population that you'd want to avoid using. Okay. This is a reasonable thought to have anytime we're talking about putting things intrathecally or epidurally. Is it neurotoxic? Presumably, probably not because of clonidine and its use. Unsurprisingly, again, there's limited research that's been done in humans to demonstrate this for or against. There's some mixed data in the animal models. This paper is one that gets tossed around pretty commonly as kind of highlighting the boogeyman of what epidural dexmedetomidine could do. So this was a group of bunnies that were epiduralized, and then they had their heads chopped off. The group that was given just dexmedetomidine in their epidural, there were findings of demyelination of oligodendrocytes in the area around where their epidural had been placed, so potentially neurotoxic to important structures. That being said, and pretty quickly, a lot of the papers that bring this up then kind of bat it down immediately. They point out that this was a per kilo dose of around 6 mics per kilo, and any of the human trial stuff that's being done for neuraxial, it's usually no more than about 0.2 mics per kilo. For epidural, it's no more than about 1 mic per kilo. And again, even these are on the high side. Most of the stuff that's being done is quite a bit less than this. So while it is possible, maybe not. This might be a heavy dose related type thing. Additionally, there's a handful of other papers that all look at how dexmedetomidine might actually be neuroprotective. There's one looking at mechanisms and kind of a summary of animal studies. The second one looks at intrathecal dexmed versus methylpred in a spinal cord injury model in rats and found that it was equally effective in, again, neuroprotection. They looked at rat fetal models on brain development, and again, it seems to provide cortical neuroprotection during a growing brain. So the data is objectively mixed and not very good. Okay, so a little bit to summarize then what I've tried to get across around neuraxial dexmed. Really, this hasn't been a talk in trying to scrape out, is it better than opioids? Is it better than et cetera, et cetera? It's more of just an introduction because this is something that's not really done here. So a good way to do that, I thought, was a pro-con list. Reasons that it seems to be of benefit. So no respiratory depression or pruritus that's being seen when used in this way. It apparently seems to have a good safety profile so far. Again, data is limited, but it looks like it's good for you. Improved block depth, motor blockade for C-sections, improved onset time for blockade, improved length of blockade, improved control of shivering, and improved post-op analgesia. Some of the negatives, so practically Dexmed isn't always available. It's not always in Pyxis, so sometimes you have to hunt for it. The concentrations that we have are very high when you get it in the morning, so you would use it for a day and throw the rest out, so it might become expensive if we don't have other options. It's not widely adopted here. So if you're planning to use it, you don't have a friend that you can just say, hey, how did that work for you? What kind of doses are you using? There's really not a support base here that you can look at. We talked about bradycardia and hypotension as fairly common side effects. Again, you don't see nearly as much of this with these perineural applications, but it is still a possibility. Not all formulations are preservative free. So this is something that you would have to check when you're using it. You don't want to be putting preservatives, again, in and around the spine. I have confirmed on the AH side, at least with pharmacy, our formulary is preservative free. But again, still something you'd have to check. If it goes on back order, it may not be. And I didn't have time to reach out to the Covenant Pharmacy after I'd talked to this fellow. This is questionably defensible if complications arise. Again, just because it's not really being done here. It is being done. And again, there does seem to be evidence for it being safe. But the burden of whether you feel defensible would be on you and the papers that you've kind of chosen to base your practice on. And in that same vein, despite what it seems to be a good amount of evidence for safety, no one appears to be willing to say, yep, go for it. Looks like it's safe. It's almost the same word for word at the end of all of these papers is that while it has a good safety profile and appears to be efficacious, the data is lacking and we need more research. Okay, so I said I was going to talk a little bit about dosing. I've got two slides here. One is sort of what it is mentioned in the papers, and then I took one from my notes on CAS, what people were actually doing. So infusion dosing, typical infusion loading dose, 0.5 to 1 mic per kilo given over 10 minutes so that you can kind of mitigate a little bit that hypotension and some of the more intense bradycardias. And then an infusion rate of 0.2 to 1-ish mics per hour, often around 0.6, titrate to effect. I've used it once. Dr. Brown and I did an awake cranny, and this is effectively what we did. Worked. Shivering in PACU, usually bolus dose recommended 10 to 30 mics. You can give it push. You don't have to worry so much because this is a fairly low dose about the side effects. It tends to be pretty well tolerated. Epidural dose was 5 to 50 mics or 0.5 mics per mil in your infusion. There was no clear consensus. They were really kind of all over the place. With the spinal dose, the data seemed to be a little bit more concise, actually. So people were between 3 and 15 mics. Again, no clear consensus, but there were a couple papers that talked about how above 5 mics, there didn't really seem to be any additional benefits. So this has been suggested as an optimal dose. And then when we look at what, again, these two individuals were doing at CAS in their OB practice, IV, they were using it for periop anxiety. They would give a bolus of about 20 mics, and this tended to be pretty close to what you'd see if you give a little bit of Fent or Midaz or something for like positioning a patient for an epidural. For shivering, the one practitioner that was using this was 12 to 16 mics. It's really weird numbers. They had used it enough in their hospital that they had spoken to pharmacy. They had pre-made syringes that were in their Pyxis. So this is basically the amount that was left after they'd done some epidurals. And this seemed to be enough to get a good response. They would give this during the C-section when the patient started shivering. You'd throw this in the IV, and it tended to work. Generally, they were recommending 10 to 20 mics, ceiling of 30. If you give one, you can repeat it. And they were finding that by and large, this was working very well for intra-op shivering. For their spinals, neither of them really used it in their spinals. I think part of it is there's just a little bit more of that mental barrier to get over, putting it into the spine versus next to. And more than that, potentially too, is that they didn't really need it. Spinals come on pretty quick and they're nice and dense. So epidurals is where they differed a little bit. So one practitioner, he was mainly using his in his top-ups. So he would do about a quarter mic per cc in his top-up bolus. So 2.5 mics he would add into his 10 cc syringe. For found that that had a good effect. He didn't get called back. The other, she was using it more with her epidural starts or when they were converting from a labor epidural to a C-section epidural. She would give 20 mics in her local bolus. She found that it did provide a more dense block, faster onset, and it reduced her conversion rate to GAs. Again, anecdotally, neither of them had written down or recorded all of their uses, but this is what they were tending to find. And then both agreed that it was very useful for fixing patchy blocks, blocks that were kind of working, but they're still having pain. This seemed to make a difference for those. Okay, so in terms of recommendations, ultimately it is an off-label. You have to take a page from the anti-vaxxers and do your own research. You'll have to watch at least one YouTube video before you put dexmedetomidine in the spine. And I'm pretty much going to parrot all of the paper's final words in saying that, again, it does appear to be quite efficacious. It does appear to be safe, but in terms of robust safety data, robust use data, it just doesn't exist yet. And again, it's not really there's no one here that's doing it. So you're going a little bit out on a branch if you're doing it. Cool. All right. We can now take any questions.
Am I correct in thinking that most of the comparative literature compares neuraxial slash block dexmedetomidine versus no dexmedetomidine as opposed to systemic dexmedetomidine?
So the question was if the literature is mostly looking at, with neuraxial stuff, dexmedetomidine versus local versus as opposed to dexmedetomidine IV and blocks. Yeah. So there are papers that do look at both, and actually the evidence is similar in a lot of cases.
That's the same outcome?
Yes. Yeah. So you're getting, I didn't want to dig too much into that because again, you can get pretty far afield quickly, but for the most part, the data looks like running an IV Dexmed infusion beside your regional or neuraxial application, you get a lot of the exact same benefits. You do get more of those IV side effects. You see a little bit more of the bradycardia associated with it. But you do still get, because it is still acting on the central and the peripheral alpha-2 receptors, you do still get a lot of that block depth, block duration benefit. Yeah. Yeah. So Dr. George brought up a few points. He does use it occasionally. So he has put kind of that 0.5 to 1 mic in some of his paravertebral blocks, and he's found that there is a fair amount of systemic absorption. Patients are quite sleepy. He's also done a little bit of the kind of that post-op push, and he's again found that pushing more than 10 mics IV can get a fair amount of rebound hypertension. And then there was also comments about he also again has used this in spinals with good effect, kind of in keeping with what we've seen, and a little bit of questioning about really why hasn't it been adopted here. It does seem to be mostly cultural, but the flip side of that is it can cause problems with sort of same day discharges. People are a little bit more sleepy, a little bit more blocked for longer. Oh, and patiently. Mhm. Another comment that the the potential price of this comfortable patient is that they're while awake, they're going to complain incessantly about a dry mouth. So use at your own risk. Okay. Any questions from Zoom? I don't see anything on the chat. Okay. All right. Anyone else in the room? Okay. Thank you very much. Hope it was fun.